Welcome to The Public Health Gap, a podcast examining why evidence-based public health programs often struggle in real-world settings, and what it takes to bridge the gap between research, education, and practice. This is the podcast where we stop pretending that knowing the data is the same thing as changing the system. We examine the distance between what public health knows is true and what our institutions actually do. I am Dr. Bradley Fevrier. Today, we are turning the lens inwards. We are looking at the very institutions that claim to be the guardians of health in our society, hospital systems. Specifically, we are talking about corporate wellness inside these systems. And I want to be clear right from the jump. I am not talking about yoga mats in the break room. I am not talking about discounts on a gym membership. We are talking about wellness as an infrastructure. Because if we are honest, brutally honest, hospitals have become some of the most complex, high-pressure health ecosystems in the country. And paradoxically, many of them are structurally neglecting the health of their own workforce. We know a situation where the healers are breaking. The people tasked with public safety are operating in environments designed for burnout. And the gap between what we preach to the community about prevention and how we design our own internal operations is exactly what we need to dismantle today. For the next few minutes, we are going to explore why resilience has become a dirty word of sorts in nursing, for instance, and why HR cannot solve clinical burnout alone, and how we move from performative perks to structural prevention. Let's get into it. For years, hospitals have positioned themselves as anchor institutions. If you look at any non-profit hospital's tax filings or their marketing materials, you see the same language. They conduct massive community health needs assessments. They launch prevention campaigns for diabetes and heart disease. They also advocate for upstream interventions in housing and food security. They tell the community, your environment dictates your health. Where you live, how you work, and the stress you carry matters. And yet, inside their own walls, that philosophy vanishes. Workforce health in a hospital system is rarely treated as an environmental issue. It is treated as a personal maintenance issue. It is delegated to HR, framed as employee engagement, and funded as an auxiliary function. A nice to have, provided there is budget left over after the capital equipment purchasing is done. This contradiction deserves deep scrutiny. Because hospitals are not just healthcare providers, they are major employers. In many rural and suburban regions, the hospital system is the economic engine. They are the largest workforce hub in the community. This means they aren't just delivering health, they are shaping it daily. They shape it through scheduling structures, rotating shifts, 12-hour stints, mandatory overtime. They also shape it through benefit design, staffing models, organizational culture, the hierarchy, the psychological safety. That is not just a job. That is infrastructure level influence on human biology. But it is rarely treated that way. Let's ground this to something tangible. I want you to imagine a mid-sized regional hospital system. Let's say they employ about 1,200 clinical and administrative staff. Over the past 3 years, the data tells a specific story. Overtime hours have steadily increased, not just during the surges, but as a baseline. Short-term disability claims for stress and musculoskeletal issues are rising. Behavioral health claims have climbed 40%. Nurse turnover unaccelerated, specifically among those with 2 to 5 years experience. When these employees leave, the exit interviews are consistent. They do not cite pay as the number one factor. They cite exhaustion. They cite a lack of structural support. They cite the feeling of being a cog in a machine. And how does the average leadership team respond to this data? They schedule a resilience workshop. They bring in mindfulness coach for a lunch and learn that nobody has time to attend really. They launch a quarterly walk-in challenge. They build a subscription to a meditation app. Now hear me clearly. None of these initiatives are inherently harmful. Meditation is good. Walking is also good. But applying a walk-in challenge to a nurse who just walked 18,000 steps on a 12-hour shift without a bathroom break, that isn't just ineffective, it is insulting. This is where the concept of wellness fails. When wellness is treated as programming instead of infrastructure, burnout persists. Because burnout is not an individual failure to mediate. It is a predictable outcome of system design. I want to go deeper into the idea of system design. In public health, we use a framework called the hierarchy of controls. Usually, this is used in occupational safety, like handling toxic chemicals. The least effective way to protect someone is to tell them to be careful. PPEs, right? The most effective way is to remove the hazard, elimination, or engineering controls. We need to apply this logic to psychological safety and workforce health. Currently, hospitals operate at the bottom of the pyramid. They rely on the individual worker to protect themselves through self-care. System issues, chronic understaffing, hospital solution. Here is a webinar on stress management. This is a resilient deficit model. It assumes the worker is the variable that needs to change. But if staffing ratios require chronic overextension, exhaustion follows. This is physics. If scheduling models do not allow for circadian recovery, metabolic strain compounds. This is biology. If mental health services require navigating a fragmented third-party employee assistance program that takes 6 calls to get to an appointment, utilization drops. That is a bad design. This isn't a resilient problem. This is an infrastructure problem. Public health literature has emphasized this for decades. We teach our students: 1. Environmental design. Make the healthy choice the easy choice. 2. Public policy alignment. Rules must support the goal. 3. Upstream interventions. Fix the leak. Don't just mop the floor. We teach that behavior is shaped by structure. And yet, inside the hospital, we revert to individual level coping strategies. Let's look at a scenario I saw recently. A hospital system notices rising behavioral health claims and compassion fatigue among the ICU nursing staff. Leadership does the standard thing. They contact a high-end corporate wellness vendor. Employees get a beautiful app. It has sleep stories, step challenges, and a digital coach. Month 1, engagement is high. Everyone is curious. Month 3, participation falls off a cliff. Leadership looks at the dashboard and concludes, staff just aren't engaging. Maybe they don't care about their health. But a deeper analysis, a structural analysis, reveals the truth. Shift rotations remained unchanged, flipping days to nights rapidly, for instance. Staffing shortages perish, meaning no one could take a break to check the app. Mental health appointments still required a $40 copay and a wait list. Supervisor training on workload management was non-existent. The app was not infrastructure. It was a surface intervention. And surface interventions cannot compensate for structural strain. Now, I know some of you listening are thinking, Bradley, this sounds expensive. Structural change costs money. Apps are cheap. Let's talk about money. Let's talk about the economics of the Perk system versus the infrastructure system. Hospitals operate on thin margins. I get that. But the cost of ignoring workforce infrastructure is compounding daily, and it is usually hidden in the general ledger on the different codes. When clinician burnout increases, the consequences ripple outwardly structurally. 1. Recruitment costs. Replacing a specialized nurse costs 1.5 to 2 times their annual salary. Temporary staffing. When your staff burns out, you hire travel nurses at a premium rate. That is a direct tax on your inability to retain talent. Production and error rates. Exhausted humans make mistakes. In a hospital, mistakes lead to readmissions, litigations, and also lower reimbursement rates. Also, patient satisfaction. Patients know when the care team is drowning. They feel it. Scores drop. Reimbursement drops. Burnout is not only a moral concern, it is a performance variable. And performance variables require structural solutions. As healthcare decentralizes, employers are becoming health system nodes. Hospitals, as employers, are not immune to this shift. If a hospital system wants to lead prevention externally, they must architect prevention internally. What does prevention as an infrastructure actually look like? It looks like this. Integrated mental health. Not a phone call or not a phone number to call, but embedded behavioral health support that is confidential, that is free, and on site or immediately virtual. Scheduling models. Algorithms that flag when a staff member is at risk of fatigue before the schedule is published, not after it is worked. Benefits literacy. Clear pathways so that utilizing care does not require a PhD in insurance billing, for instance. Longitudinal tracking. Measuring workforce health the same way we measure patient population health. This is not soft programming. This is operational design. So how do we fix this? How do we close the gap? The deeper question is this. Why is workforce health often framed as HR territory instead of executive strategy? In most hospitals, the wellness director reports to the VP of benefits, who reports to the CHRO. They are 3 steps removed from the CEO or the board. Prevention is rarely brought into governance conversations until there is a crisis. Health promotion experts are rarely embedded in operational redesign. If prevention is truly upstream, then upstream thinking must begin inside our own institutions. To the hospital executives listening, you need to integrate public health expertise into your decision making at the structural level. Do not hire public health pros just to run your community outreach. Hire them to analyze your internal population. We need to be architects involved in design, not consultants called in after turnover spikes. To the public health professional listening, we have to stop shying away from the corporate side of healthcare. I know, we like the community side. We like the non-profit side. But hospital workforce systems represent concentrated population environments. Thousands of lives, predictable schedules, defined benefit structures, established communication channels. If we ignore employer ecosystems because they feel corporate, we forfeit one of the most powerful levers for adult prevention we have. We need to enter governance discussions. We must understand finance. We must analyze workforce modeling. We must also collaborate with CFOs, not just the Chief Nursing Officer. Otherwise, prevention remains theoretical, while strain becomes structural. This is not about criticizing hospitals for the sake of it. It is about confronting misalignment. Hospitals invest heavily in clinical excellence. They buy the best MRI machines. They build state-of-the-art surgical suites. They obsess over accreditation. Workforce health deserves equivalent structural seriousness. When wellness shifts from a perk to infrastructure, design decisions change. When design changes, strain reduces. When strain reduces, outcomes stabilize. And when outcomes stabilize, the hospital actually becomes the anchor institution it claims to be. Over the next several episodes, we will continue expanding this theme. We are going to look at specific matrices. What should you actually be measuring? We'll look at how to scale these initiatives operationally, because decentralization does not eliminate responsibility. It redistributes it. And the hospital systems sit directly at the intersection of care delivery and workforce infrastructure. That dual role cannot be ignored. That's today's episode of The Public Health Gap. If this challenged your thinking, I want you to share it. Send it to your Chief Nursing Officer, your HR Director, or that colleague who is tired of surface-level fixes. And if your organization is ready to rethink workforce health, moving from engagement programming to structural infrastructure, strategic advisory sessions are available. You can find us at the nextgenpublichealthconsultancy.com. And remember, no episodes examine how evidence is translated or lost as public health programs move from research into practice. New episodes of this podcast drops every Tuesday. Also, you can subscribe to our newsletter. Don't forget to listen and subscribe wherever you listen to your podcast. Until next week, stay focused on systems, not symptoms. Thank you.